So, good afternoon. I will be talking about the physiological aspects. Whenever you put some gas inside, what are the physiological changes that takes place? When we may trespass and cause morbidity and mortality. Most of the things is because of the gas under pressure. That's why I have said what you should know before trying to put a gas inside the thing, and what are the precautions you have to take. And also, what is the need to undergo this training? That is very important. What is accreditation? Why we need a certification? And how to prevent mortality and morbidity during laparoscopy, and how to improve the quality of care and how to improve the patient comfort when they come, and what are the anxieties from the patient side, and how you convince a patient when his patient is in front of you in the OPD. So, this all started with a mortality. A London lawyer lost his wife during after peritonitis following perforation of the bowel during this one. Then he started finding who did the surgery, what is their qualification, what is their experience. To August, he came to know that there is no such certification, just a training and the self-learning like that. Then medical council and all, they woke up. It became a big media thing. Here doctors are doing surgeries, very high risk surgeries, and without any proper quality. Then it made mandatory that anyone who does laparoscopy or whatever it is, you should have a proper training and some sort of a examination, whatever you call, accreditation and certification. That's how all this came into existence. So once you are certified, even your patient will ask, what is your training, what is your qualification? You cannot say this, I went and saw something and I am trying to experimenting on you. I don't think that is the thing. Nowadays we got media and everyone, whoever comes would come with this one. So I try to give the physiological background. What is unique to laparoscopy when you are all stalwarts of open procedures, but in what way it is this one? What are the hemodynamic trespass that can take place, and how to recognize and manage? That is very important. If you don't recognize it, so what we say is you tune your ear to the BP heart rate sound that is coming. If there is any bradycardia, don't look at the anesthetist or anyone. Just deflate it. Deflate it. Afterwards, you look whether the anesthetist is awake or looking at the mobile. That's how, that kind of a tuning is very, very important for you. You should know. If a pulsation is not there, when you put this one, there is no pulsation of the mesenteric vessel. You know that there is something wrong. Hypertension is there or patient is already arrested. That kind of a intuition must be there, awareness must be there in all of it. Then only you can recognize even before anyone, because you are the leader of the whole thing. Surgeon is a leader and he is the one who guides, and but perception must be very, very important. And also I will tell you a lot about morbidity and mortality that has occurred, because from the day one we have got recording here. All the cases we have recorded, and we have got another file for whatever the morbidity, mortality, wherever the complications have occurred, so that we can review it and correct it. That's why we have equipped our theatre, and whole thing is according to the prescribed norms, so that no one should say, we went on, that was not there, this was not there. That is not the way it is. And also, we will be telling you about how to comfort the patient after the surgery, and what are the patient's anxiety. Those things will be there, and something about the recent advances and safety and quality care of your patient. So as you know, the word laparoscopy came from Greek word, and also it got a component about the Latin also. Those are the things. That again, looking into the abdominal cavity, that's all it means. insufflation from the abdomen with a gas or other fluid. Previously they used to put fluid inside the abdomen, and then they went to air, then carbon, other gases. So Hippocrates is the 4th century. At that time itself, they are wondering about the light and the how to light source, how to see, take the sunlight and reflect, and lens and reflectors are all they are trying to invent, so that they can see something inside the mouth and other things. Then came the other type of different thing. They want to see the throat and internal organs, but they started Petromax or something, some illuminating things with lot of mirrors. They were trying to direct and focus the light. Then came the other type of turpentine and spirit they were burning, and that was like a Petromax. They tried to use it. Then came the sword swallows. Then they were wondering why not we put something inside the mouth and to the esophagus and see the inside the stomach and gastric contents. That's how they thought of doing something looking into the stomach. Then came the Kelly, where the first visualization inside the abdomen started, and then the insufflation came into this one, so that we'll have some sort of a window, so that we can go inside and see. And then came the gynec procedures, fallopian tube ligation and other things. And most of the improvement occurred during with gynec procedures. And he is the one who did the laparoscopic appendicectomy and caused, and everyone was laughing at him, because we will finish appendicectomy in 20 minutes, you take 2 hours or something like that. They were laughing at him. Then came the instruments. This kind of even today we are using a rigid scope, where will be round lenses will be there assembled in a tube. That's what even today we are using it. That's called rigid rod lens telescope. That's the scope that we are even today we are using it. And then came the camera and documentation. They started attaching the camera and trying to do the surgery through the camera. Then they thought of having a cable and visualization. And then came the maximum number of cases and familiarization with the gynecological procedures. And the clips and all were introduced at that time to have hemostasis. So this is also called so many other names: endoscopic surgery, endosurgery, and this one, video surgery, robotic surgery. All that means same, but different names are given in different thing. So we have got different types of laparoscopes also. We have got, as we said, digital laparoscope that we have started using now, and that flexible endoscopes are on the way. And we can say the benefits, because we are selling a new technique, we'll be telling so many good things about it. That is a small incision and pain is less, no scar, and shorter hospital day, and there is no loss of your earning or whatever it is, faster recovery, and you can attend to your work without hospitalization. Before, whole month used to spend on one surgery. So what are the evidence that to say that laparoscopy is better than open surgery? That is one thing. Whenever we put an incision and a surgical stress is there, there will be release of stress hormones and immune response and those things. That is any increase in intra-abdominal pressure, and that will lead to lot of changes. So there are a lot of argument, because we are trying to induce lot of trauma during insufflation. At the same time, it is better to open and do the surgery. Then they did a lot of surgery studies eliciting a neuroendocrine response via hypothalamic pituitary adrenocortical axis, and to know what is the stress hormones, how much it will come, what are the other glucose metabolism and other things that may derangement that may take. So to make it very short, they compared the open surgery, 100 open laparoscopy and 100 lap surgery, and convinced beyond any doubt this is less stress, and that's why the patient will recover fast and he can be on his feet quickly. So now we have no doubt about the advantages of laparoscopy. That's why it is living, and it's going to live for and improvise further. So what is unique to laparoscopy surgery? You all know already. It requires a high pressure gas, or called pneumoperitoneum or carboperitoneum, to create a window so that abdominal wall is lifted, and so that you visualize the organ that you have to operate. And that may lead to that's the main component that may lead to a lot of complications. At the same time, whatever the organ that you are operating should be at a higher level than the rest of the viscera, whether it is uterus or gallbladder. So we have to adjust the pressure, either pressure, and also we have to adjust the level of the table. So we give head low position or head up position. That may add on to the complication that may occur during this one. And we all know the gynec procedure, where we lower the head end and put the legs up, will increase the morbidity and mortality up to 40% when compared to head up position. That we know, that we are going to discuss little later. So when a patient is in front of you, you should know whether this patient can tolerate this kind of insult. That's what you should know, and what you have to tell the patient, and how to take consent and other things. And also it is complicated by unintentional, unsuspected visceral injury, vascular injury, or cautery burns that may occur during this one. And also it is because of the position, you will not know how much of blood loss that has taken place, because now our visualization of number of mops and other things, suction, all that may not be there, because blood will be collecting at a dependent position. So there is a difficulty in assessing the blood loss. And most of the complications during this one is a blind procedure, that is the insertion of the primary axis or a primary port, because that is under totally blind. It is your luck and patient's luck. So that's where the maximum number of accidents have occurred, and that has ended in thing. And at the same time, because of a new technology and all, it may take more time than open procedure, and there is a odd lack of information and lack of knowledge about it. So we tend to take it very casually, thinking it is very safe procedure and I can finish it off, and overconfidence. All this will lead to, because you are not prepared for the complication, because you have no much audited information about it. At the same time, nowadays, because of the fast track, most of the patients come as a OPD basis. They also come down, you also get out of the car, and both of you go to the theatre. That was not the situation before. We used to admit them, we used to optimize them, we used to investigate them, and for two days, and hydrate them, then give the antibiotic, then we bring them to the theatre. After the operation, also they used to be with us for 2 to 3 days, and that was the usual. Now it is fast track. They come along with you. We expect to go discharge before you leave the hospital, and that's why the preparation, pre-medication, optimization, all that are the things that we don't think of those things now. And also we have got a diverse population now. Because of the physical condition and medical condition, we were postponing, we were not doing laparoscopic procedure. Now we do high complicated cases we are doing under laparoscopy than open procedure. That the reversal has occurred. So we have to have a proper setup and proper backup for the taking high risk patients. And also, as you know, that age also is not a contraindication, and we have got additional remote surgeries and robotic surgeries, and those are the things that are coming. And also where we are doing in a cramped, dark place and surrounded by monitors, multiple equipments, and everyone is looking at the monitor and forgetting that there is a live patient on the table who is undergoing surgery. Even anesthetist may not be able to even touch the patient or feel the patient. We used to keep our finger here and give anesthesia. Now it is impossible because of the so many things and attention. So we should be very careful about organizing the team, and at the same time you would have told in the OPD and the patient, it is a very minor procedure and you can come and you can go, and we are lighten the whole procedure. But if complication occurs, you have no face to explain that went wrong, this went wrong and that, because you are already told, committed to the patient. That's where you should know where you stand and how to commit. So now, as you said, major issue is about the pneumoperitoneum or carboperitoneum and other things. So as I told you, most of the deaths have occurred at the time of initiation of the pneumoperitoneum. As soon as because as I told you, it is a blind procedure. Primary port is by a sharp instrument that we are trying to put it inside and under. Secondary ports are always under vision. We know where it is coming, how it is coming out, this one. So we have got two methods. One is Hassan technique or open method, where you under vision we put a blind thing. So that is very safe. But other is varus needle, where we put almost under this one. Can you read? I want you to read. Read.
Capnography aided diagnosis of gastric perforation during gynecological laparoscopy. This was
Okay.
published in Liverpool in 2008. It's a case report. After confirmation of varus needle position, carbon dioxide insulation started. It was immediately noticed an abnormal ETCO2 raise with a rapid upstroke. While checking the position of ETP, it was noticed that air was escaping from the mouth. A possible diagnosis of intestinal perforation was made. Laparotomy revealed a perforation of anterior wall of the stomach. PaCO2 correlates well with the EtCO2.
Okay. Concluded that.
The person concluded that EtCO2 monitoring provides excellent guide to adjust the ventilation during laparoscopy.
So what are the lessons you learned now?
Need of EtCO2
It is first very good. EtCO2 monitoring is a mandatory. Second lesson you learned. Stomach must be deflated before trying to do anything. Though it is a gynec, that is the beauty here. It is not. We cannot blame that it is a patient. They are doing something. So there are some additions. Gynec thing. So emptying stomach is very, very important. Emptying bladder is a very important step, isn't it? Recognition is important. Other is gas coming from out of the mouth. Someone has recognized it. When the suddenly gas is coming. So these are the three things that you should understand. How simple monitoring is very, very essential to recognize and save the patient. So as you already said that there is no need to put arterial line and do the blood sampling. Just a EtCO2 monitoring itself is enough to safeguard the patient against complications. So what happens during suddenly we put the gas into the peritoneal cavity? There will be two things. One is it's highly vascular. There is a systemic absorption of carbon dioxide is there. At the same time, respiration, the diaphragm will be pushed up and respiratory embarrassment will be there. So that also increase the carbon dioxide and other things. So that is, and also there is a sudden stretching of the neurovascular bundle, muscle and other things. That is the cause for your postoperative pain and discomfort and shoulder tip pain and other things. So these are some of the physiological normal things occur every time you put a gas inside the abdominal cavity. So this is how we will be setting a thing. This is the new introduction. It has got a mode. Just while putting the various needle, it goes into different mode. Otherwise we said rule of 2, 5. Rama will be asking, all the time he will be asking, what is rule, what is rule, what is rule. So now we have got a different, specially designed for this one. As we said, when you put the gas inside the abdomen, the first and foremost thing is diaphragm. They put sensors on the diaphragm to see how much of pressure that will exert and how much of gas when you put. Say you put the gas up and keep at 15, and what is the pressure that is reflected on the diaphragm that they have done? That is about 50 kg square meter. It will be so much of pressure will be there. So that will push the whole thoracic content into the thoracic cavity, and that is how the mediastinum, whole mediastinum will be shifted up, and it spins the diaphragm, and that will cause increased intrathoracic pressure that may reflect to the intracranial pressure and also intraocular pressure. So there is always, it is waiting where the gases can escape because it's under high pressure. So there may be migration, and also it causes pneumothorax, those things can occur. And also, as I already told you, abdominal muscle wall will be torn and peritoneum will be stretched, and there is a tamponade effect because of the pressure, increased pressure. The circulation to the viscera and kidney and the uterus will be reduced because of the tamponade effect, because of pressure. So this is just to show you how a normal thing, once you put the gas, how it will become like this. It looks normal, it looks so abnormal. You can see the gas under the diaphragm, and if you see this X-ray preoperatively, you operate on this patient, if you ask, you will say, no, let us refer to Dr. Ramesh. So that's what you are going to do for every patient. That you should understand. As I already told you, the gas can go at a wrong point, wrong plane and wrong direction. That's where we should be very, very careful that it is in the peritoneal cavity. It can become a subcutaneous, it can become a surgical emphysema, retroperitoneal emphysema, pneumomediastinum, pneumopericardium, pneumothorax, systemic effect, and carbon dioxide also will be absorbed into the system and always have danger of gas embolism. So once we are talking about the pneumothorax and other things, as you said, there will be collapse of the lung, and because we have put an endotracheal tube on ventilating the patient, you may not see dramatic changes. But if a patient is on spontaneous respiration, it may become more important. This is again during gynec surgery, they have produced unilateral pneumothorax and hemothorax, again during gynec procedure. I am not going through it because it takes time. And this is another thing, the diaphragm is already stretched. If it starts vibrating, you know that there is a pneumothorax. These are the reported mortality after laparoscopy, where there is the pulmonary thromboembolism, especially during COVID condition, during cholecystectomy, capnothorax during laparoscopic cholecystectomy, death of a patient. This is another thing that all the anesthetists should be aware, because we told you that mediastinum will be shifted, and though you have checked the endotracheal tube, it may slip into the right main bronchus. That's why normally we put the tube at 22. In laparoscopy we put at 20. So we pull the tube and fix it so that even if the movement is there, that will not become this one. As I told you, the prolonged deep pressure, head low position may cause cerebral edema, and better to take anti-edema measures instead of trying to treat the edema, because patient may not be very alert at the end of the operation. So when you ask for a position, head low, you will be asking all of you. So you should just remember that what are the things that may happen. So what I was telling about something about tamponade effect, that is increased intra-abdominal pressure over the capillary perfusion pressure causes ischemia of the gut and mechanical compression. That may lead to this splanchnic and mesenteric ischemia and metabolic acidosis. And most important thing that we are really worried about the acidosis during this one. At the same time, the urinary output. So whenever there is a catheter is there at the end of the surgery, all of you should monitor, go and observe how much of urine came out during the surgery, and that you have to be documented. So that will give an idea that not only that you have not caused any injury to the ureters during surgery, at the same time you have managed the patient with a proper fluid intake and thing, because the head low position, there may be. These two things are very, very important to know the renal system, because urinary output is very important to correct the metabolic acidosis that takes place in the body. So now we know the two positions, and head low position and head up position. I told you about the reverse head low position, and a side tilt is usually given during upper abdominal surgery, and there is always a possibility of pooling of the blood, and venous return will come down, what you call preload will come down, and afterload also will come down, and pooling will occur. So if a patient has got a low cardiovascular integrity, then they may become more hypotensive, suddenly hypotension. That's why we give the position in a graded manner. Suddenly we don't increase. At the same time, we would have given IV fluids to hydrate the patient very, very. Those are very important. And whenever there is a pooling of the blood, always there will be possibility of thromboembolism, especially if the tights are there on the leg. All the triads are met there, stasis is there, hypercoagulability is there because of the long procedure. At the same time, there will be injury because of the straps that they put. So you should be very careful. And you might have seen at the end of the surgery, Dr. Ramesh will put the leg of the patient on this one, and will be cough muscle will be squeezed. Most of the surgeons do it, especially in a major surgery. And anesthetist will not be asking to open the tongue, show the tongue. He will be asking to move the feet. That's how you know he is a laparoscopic anesthetist. We don't ask them to show the tongue. We want to ask them to move the leg. That is very important for us to see that patient has not developed any complication during surgery. So, what is the gas we have to put in? What are the physiological characters that you should have to produce all this one? So, it have minimal peritoneal absorption. High blood gas solubility is very, very important, because whatever the gas that is there, that should dissolve into the blood, absorb into the system, and it should be expired out and by the lungs. And inert physiologically, inert pharmacologically, non-inflammatory, because we will be using cautery. So when we go by the physiological basis, it is amount of gas dissolved in the blood to eliminate at a rate. So Oswald blood gas partition coefficient says volume of gas that is in the 1 ml of blood. So which is saturated to 1 cubic centimeter of the blood. So that if you take that one as there, you can see the blood gas solubility, and when you compare to all the gases, carbon dioxide stands out so that easily it will be absorbed into the system, easily eliminated by the thing. If it does not absorb, then there is a possibility of complications like embolism and shoulder pain and other things. So previously they used to use air. Some of you might have used air for sterilization and other procedures, fish tank and other things, pumps, they may use it. And again, there used to be a lot of complications, and this is all right for a short procedure, not for a major procedures. Then they try to put nitrous oxide, nitrogen, helium, oxygen, all of them are not an ideal thing. Then the latest is argon and xenon, they are under experimental conditions. So we come back to the gas that we are familiar and we are using every day. So as you know that it is a odorless, non-toxic, non-combustible, and allows you to use the cautery, and it is 28 times more soluble in the blood than air. That is, blood gas solubility coefficient is 0.8. So significant vascular absorption will take place, and it is readily buffered by the bicarbonate in the blood and readily eliminated by the lungs. And high margin of safety is another thing that goes well with the why we recommend this. And it is available, and comparatively it is not costly. Disadvantages are, as I told you, there is a possibility of gas embolism, hypercarbia, cardiac arrest, and other complications, acidemia, metabolic acidosis. Those are the, already there is a carbon dioxide thing is there because of the diaphragm and other thing, but we are putting more. That's why we took from 125 to suddenly it will go to 200 ml during the first 20 minutes of this one. And hypercarbia itself will cause sympathetic stimulation, tachycardia and hypertension will occur during surgery. There may be hypoxia, and it may lead to delayed recovery, and also say post-operative pain is because of the carbon dioxide that you are insufflating. Fortunately, we have what is called a plateau effect. Carbon dioxide will be absorbed rapidly in first 20 minutes, then ischemia will develop and no more carbon dioxide will be absorbed. That is the one of the mechanisms that it will safeguard against increased carbon dioxide absorption throughout the thing. This is what happens, initially absorbed and then there will be plateau, unless you put a suction catheter or try to reduce it and again insufflate. So this will safeguard the patient. But that kind of advantage is not there when you put the gas in the extraperitoneal surface. Where to put gas in the extraperitoneal surface? Hernia. That's where you should be very, 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 very careful. That is a different cup of tea. So if you put a gas outside this one, we should be more careful in these patients. And these are the patients who will never go back to the ward. They will be in ICU because this is whatever the surgical emphysema that is there at the end, that may absorb into the system, and post-operatively they may develop complications and even the collapse of the lung may occur. So usually we check them for the surgical emphysema before shifting. If there is an emphysema, we always shift them to ICU and take a chest X-ray, and we should be ready to put a needle or this. So that kind of a difference you should know where you put the gas, whether intraperitoneal or extraperitoneal. We already told about the EtCO2 monitoring and what are its importance and why it gives us the guidance about the amount of ventilation that you are doing. As I told you, we know that lung is collapsed. So immediately we put an endotracheal tube and try to overcome the ventilation and try to ventilate so that carbon dioxide level is maintained. But how much of ventilation you are doing, everything depends on the type of selection of the endotracheal tube, selection of the carbon dioxide absorption, and type of ventilation that we institute. Means putting endotracheal tube and controlling the ventilation becomes mandatory in these patients. Regarding cardiovascular effect, which is again depends on the intra-abdominal pressure, amount of gas that you have put, and it comes in a two-way. Initially, there may be bradycardia and hypotension as soon as you start insufflating. Once the carbon dioxide is absorbed, there may be tachycardia and hypertension, cardiac arrhythmias, and other complications. So we should know how to respond to these changes and what are the causes for this one. And any arrhythmias, tachyarrhythmias or bradyarrhythmias, or we have to be very careful, especially when you are operating on the salpinx or fallopian tubes or adnexa. There may be vagal stimulation and sudden bradycardia can occur. Again, it is because of the hypercapnia, and the cardia is very, very sensitive to the changes that is taking place. Next comes the pregnancy and laparoscopy. As we said that laparoscopy and incidental surgery during pregnancy, that's where we have to be very, very careful because we are worried about the two lives at that stage. There may be pneumoperitoneum. Once you institute a pneumoperitoneum, there may be a decreased venous return, uterine blood flow is reduced, and maternal fetal acidosis can occur, and that may become a major issue. So, Society of American Gastrointestinal and Endoscopic Surgery sages were awakened and issued a dictum, especially after 4 deaths occurred in 7 pregnant women who underwent laparoscopic cholecystectomy and appendicectomy during their gestation period. So, evaluation of the maternal CO2 is very, very important, and we have to take appropriate consent before, you should have an appropriate team before trying to do any procedure. These are the guidelines that they give. Whenever you try to do it, you have to follow this guideline and explain to the patient, explain to the team, and then only you try to do the procedure. So we have done cases with and these are the successfully we have done these patients and taking all the care for this. That's what, when you are counseling the patient, these are the things that they will ask you, that you should have a proper answer to all these questions that they do. And also, they are given a consent form. You should explain what's the instance of losing the baby. What will happen if can you proceed, go decide. This they should know. The informed consent should take. There is a possibility of miscarriage, possibility of premature delivery. All this is, you have to give the world statistics to the mother and convince them, and we should have a team for close monitoring of the fetal monitoring is very, very important. What do you say? So now we come to the most important, the gynec procedures. As I told you, gynec procedures are done in the head-low position and lithotomy position. There are so many things can go wrong. At the same time, pain also is more when compared to the upper person. Why more pain? That we are going to discuss little later. And pain after laparoscopic sterilization is also another thing we should always talk and counsel when the patient is there in front of you, and whether to use nitrous oxide in these cases or not, that also is another thing. As I told you, this we did a study also. Can you read? You read.
Pain following laparoscopic sterilization. It is more painful than diagnostic lab. Lower abdominal colicky pain is similar to that of dysmenorrhea. It lasts.
It is just like dysmenorrhea. Why it is so is the one which I am trying to explain to you. You can read loudly, everyone should hear.
Lasts first 4 to 6 hours. Can be discharged on the same day. More
Pain is more, you should know, because you think that it's a small thing, you can go home. It is not like that.
more pain when the rings are used.
So they have got three methods. Once you think of using ring method, pain will be more.
Then spring-loaded clips are used. Under local anesthesia, tubal electrocoagulation diathermy cause more pain than rings during surgery under local anesthesia. However, post-op after 4 hours, abdominal pain was more with ring application. Demand analgesics. Infiltration of fallopian tube or mesosalpinx with local anesthesia. The amount of pain following tubal manipulation or tubal ligation is related to concentration of prostaglandins. Prostaglandins concentrations are known to increase with dysmenorrhea. Prostaglandins PGF2 alpha is found in oviduct at 10 times the concentration found in plasma. Its localization changes at the time of ovulation. PGF2 alpha is found in the ampulla. The human ovarian follicle contains both PGE2 and PGF2 alpha in critical amounts. Lap tubal manipulation and ligation releases prostaglandins, which increases the frequency of nociceptive impulses and cause pain akin to dysmenorrhea. Therefore, it should be amenable to prostaglandin synthase inhibitors. NSAID as sole analgesic for sterilization is less effective than opioid, however more effective than paracetamol. Pain following tubal ligation can be lessened by direct application of 1% etidocaine gel on the fallopian tube is superior to 0.75% buprenorphine.
That's enough. Okay. Now we will come to Istral law. And this is nowadays we are doing a lot of this kind of surgery. There is always a danger of perforation and other complications may be there, and there is always a possibility of intravascular absorption is also there. And this is how, in a case there was gynecological hysteroscopy, that they have shown how pulmonary edema can occur very easily. This is one of the cases that happen. So whenever you're doing hysterolab, the hysteroscopy, there is when we try to dilate, there is always pain, and also there will be bradycardia and other complications. That's why we may have to attend to it by giving lignocaine and other things. And we have got different type of equipments also, so that we know it is given under controlled pressure and controlled volume. That's very, very important, especially whenever doing hysteroscopy. And we will be doing under a young woman. We are not supposed to have any complication in these patients, but unfortunately complications are reported repeatedly. This is how a hysteroscopy room looks. Can you read?
Laparoscopic hysterectomy. This is a incident reporting from on 12th February 2012. Vitals were within normal limit, uneventful. Laparoscopic dissection was almost complete. Assistant was inserting vaginal tube. There was sudden bradycardia.
injection atropine, adrenaline, zygocard was given IV, pneumoperitoneum stop, 100% oxygen, CPR, IV drugs repeated,
Ventricular tachycardia, supraventricular tachycardia.
injection amiodarone, heart rate BP restored, surgery completed under dopamine, shifted to tertiary care ICU, patient was hypoxic encephalopathy, MI was diagnosed and treated, discharged eventually.
Tell me. What could have gone wrong? It's a combined effort. You only said. What actually happened? Read loudly.
Events at the end of the surgery, the vault was partially open and there was leakage of carbon dioxide. Surgeon increased the carbon dioxide flow rate further to maintain an adequate pneumoperitoneum to visualize and operate. When the vaginal tube is inserted, this leak was stopped completely, leading to sudden increase in intra-abdominal pressure, thereby intrathoracic pressure, and which led to cardiac tamponade and cardiac arrest.
You got the message? All of you got the message? This is about using methylene blue and other things, and they may develop cyanosis during procedure. You should know about it. So there are certain aspects about giving regional for laparoscopic procedures, especially gynec procedures, and especially when a patient is not in a healthy condition, they think that the regional can be better than giving regional. Some of the centers are practicing it, but you should know that patient may become worsen the condition, start hiccuping, complaining of pain and other things. You should have a method to convert it, or give intravenous sedation and also regional block. That's very important. That depends on your experience at the center and how do you manage it. And you should always know that any laparoscopic procedure, as I told you, you should have protect the airway, control the ventilation, eliminate the carbon dioxide, then only it is safe. Anything other than trying to do with ketamine or something like that, you land in a major problem. This is what you call 100 minutes mandatory monitoring of these patients. So whatever the carbon dioxide that is absorbed into the system, it takes about 100 minutes to get out of the body, and normal gases, whatever the nitrogen and other things, will come back. And whatever the derangement that has occurred because of the carbon dioxide and acidosis and other things takes about 100 minutes. So the most crucial time after the laparoscopy, because you will be concentrating on the next patient, forgetting that first patient has gone to the ward. What will happen to the patient? Where is the patient? By the time the nurses recognizes or come and you change and run to revive, it may be too late. So whenever you try to have a system, you should monitor the patient for first 100 minutes under your care. That's why we have put a oxygen monitor, oxygen availability, and a nurse in the immediate postoperative period. Then only they should go to the ward. No patient should go directly from OT to ward unless you have got a vigilant nurse, or any high risk patient should go to the ICU. This is very important for you whenever you are trying to set up a center or whatever it is. First 100 minutes is very important, especially if a patient is shivering. You should know that patient will not be able to breathe properly. They may become cyanosed and anything can happen. At the same time, it is mandatory to administer oxygen for first 100 minutes. These three things are very important to prevent postoperative complications, and this is the golden period after the surgery, and you should not lose track of the patient.
Even for a minor procedure?
This is the
Sir, is it required even for a minor procedure
what is minor procedure?
like DHL, diagnostic laparoscopy? Even for those patients, should be admitted to the ICU then?
You have put, I told you there will be carbon dioxide absorption into the body system, isn't it? It has to go out. Minor patient, if you lose a minor patient, what will happen to you? That is where you should be. That's where you lose our track. We think we are very fast, very, very smart and very fast. You have to pay a heavy price. Please don't do that. We are no, afterwards can you go and explain into this one, because it is a minor accident, I forgot about the patient. Can you say that? No, you cannot. Please don't do that. There should be a system. You have taken all the care. More than that, something happened, then they will save you. Otherwise, they will not save you. Okay. Unless you are 100% sure that patient is all right and very, very minor, you have to take a decision. Your experience will teach you everything. This is most confusing and most misunderstood thing. We all think that laparoscopy is very, very simple. If I infiltrate a little local here, that is the end of the thing. Patient should be able to go home and play tennis. It is not like that. It is never like that. This is all the surgeons, irrespective, they think that they have not done anything to the patient. That's why this is most misunderstood, and that's why we lose this one about the confidence about the laparoscopy. Patient will suffer and will never excuse you afterwards. They told me that I can go home, and then I had that pain, this pain, 3 days I could not move, and they don't. That should not happen. You should be truthful. You should know physiologically what you are doing, why you are doing, what did you do to the patient. Because you are not seeing, it does not mean it is not there. That's what we have got. Abdominal wall pain is there, somatic pain is there, visceral pain is there, shoulder tip pain is there. There are about 4 types of different pain will be there postoperatively. Abdominal wall or somatic pain is first 24 hours. There will be severe sharp pain will be there. Right upper quadrant and port site wounds also will be there. Postoperative pain correlates with the preoperative pain threshold and procedure that you have done, and how long you have done, what are the intra-abdominal pressure that you have kept during the procedure, what is the position of the patient, all that will come into this one. And also hypothermia, whether there is any hypothermia. So all these are the contributing factors that you should remember. Abdominal wall and some, as I already told you, women report more pain than men, and also in a head-low position. Exact mechanism is very difficult to make you understand and make you convinced, is because it is all theoretical, and lot of experiments and other things are going on, and basically it is rapid distension and stretching of the peritoneum, diaphragm during the initiation of pneumoperitoneum, leads to the tearing of the nerves and the blood vessels and abdominal wall muscles, and release of inflammatory mediators, and peritoneal biopsy has proved all these things. This is rhabdomyosis that they have done this study, and this one. This is very, very important. So different intra-abdominal pressure at 6 millimeters, this is the response. If you increase the pressure to 50, 10, it will be like that. So amount pressure that you keep, intra-abdominal pressure that you set, is very, very, very important. You should know, if you increase the pressure, you are going to cause more trauma to the patient. and more pain to the patient, more morbidity to the patient. So what we have realized is, if you give a good relaxation by giving epidural and general anesthesia, there is no need to increase the pressure so much, so that with a low pressure we can give a good relaxation, good window. Surgeon asks you to increase the pressure when the window is very, very small, narrow, cannot see. That anesthetist thinks that he is completing the procedure, might have withdrawn the relaxant. At that time you see a small spurter, you don't want to leave the patient, you want to achieve hemostasis, and that's how the problem occurs. So that's where a cooperation between the anesthetist and the surgeon and amount of relaxation that he has to give becomes mandatory to prevent postoperative complications. That's why they are not only general anesthesia, they are trying to give additional blocks also before this one, and so many things. This is the hottest topic of the day, and whole day I can talk about it. But as I told you, recommendation is told so many drugs, the multimodal methods are there. We have done a lot of studies on this one. Regional anesthesia and intraperitoneal solutions, you can put lavage, you can do all that is, and warmed humidified insufflation gas is very important. They are given subcostal block, rectus sheath block, parietal block, spinal anesthesia, and they have done a lot of studies also. Coming to the shoulder tip pain, again it is said that carbon dioxide will dissolve in the fluid, it becomes carbonic acid, that will irritate the phrenic nerve and the diaphragm. That is the cause for the pain, and it is mandatory to remove all the gas before removing the port. So can you tell me how do you do it? Can you tell me how do you do it? No gas in the peritoneum cavity at the end of the surgery. That's a mandatory rule, isn't it? How do you do it?
So first correct the position of the patient.
It's called neutralization of the patient. That is the first step. Very good.
Neutralization of the position.
Wake up the anesthetist so that he will ventilate.
And then
Ventilate properly.
stopping the inflow of carbon, inflow of the gas.
That will do.
And then removing the ports and the vision and deflating and then
Removing the port and then deflating, how do you
deflate
do? Removing which port we are talking?
secondary ports.
Secondary port we remove. We are worried about only primary port. How do you remove the primary port?
After deflation,
How do you deflate?
so gas let out.
You open it
Open
completely.
it, gas let out.
Disable the gas flow. Gas connector you have to
Disconnect.
then the valve you have to open, let the air out. After the
Come. You tell.
the telephone will have a flap. So you have to open
Remove the flap. That's very important because valve will be there.
So all the air will come out. Once all the air will come out, we can reinsert the laparoscope and see. And we can remove. Under vision,
Under vision, pull the camera back and
All that. Very good. You know what is tenting? See, cannula is like this. We take the cannula vertical, lift it, hold it. All the gas will come down. Understand? You might have seen they are doing, but you have not understood. That's why I asked this particular question. You have seen it, but you have not realized why they do it. You understood? Okay. We will do it tomorrow. So you will not have shoulder tip pain. This is the multimodal approach. We did the study using NSAID with paracetamol. We did only paracetamol, only NSAID, and when to give. This is also important. When to start, not when a patient complains of pain. So we should give before breakaway pain occurs, and this is one of the study that we have done. So we'll come to some complications and how to avoid them. Worst complication and dreaded complication is embolism. We have got two types. One is a massive embolism, other is small vessel embolism, small thing. So massive is always the gas goes into the major vessel and you are connected this one, and immediately catastrophically there will be cardiac arrest and death. Other is small bubble embolism that occurs during hysterectomy because the vessels are tethered to the peritoneum. It will not collapse. When you cut, it will open and then air may pressure, under pressure it may get in and it may cause air lock like your scooter petrol lock occurs. Then if you are using nitrous oxide, small bubble will become a big bubble and then cause obstruction to the flow. This is, I told you, this is the massive embolism. That is what we are really worried. That's why we check and before connecting the gas. And it is not our ego, the patient safety is very, very important. We aspirate, we check and we take all the precautions before. And also we give a very low flow initially, not because even if it enters, it should be able to absorb. Small bubble is whenever there is excessive ooze is there, bleed is there, hysterectomy you are doing, you are dissecting and this one, then there may be a possibility of absorption. That's why they say that put saline and dissect under saline, so that if whatever the opened vessels will get saline block instead of air getting inside. Especially gynecological laparoscopy is very, very common, and wherever you are doing extensive dissection, then this can happen. As I said, gas will get into the vessel, lock system will occur, obstruct the venous flow, or get into the heart, and then cardiac output and circulatory failure will occur. And we can recognize it, and there are so many things, but easy to say than actually recognize it. And ETCU is the one which will give us some clue. Something is going wrong. That's very important. Unexplained hypoxia. SpO2 comes down without any reason, or unexplained hypotension, tachycardia, arrhythmia, pulmonary edema, increased CVP. All this will tells you something is going wrong and you should be alert. Subcutaneous emphysema, I told you, we should be very, very careful. We should, whenever we put a gas extraperitoneally, this thing can happen. But the position itself, usually position is put by the surgeon before scrubbing, because there is a possibility of causing trauma, because patient will be in this position and head low, head up will be doing. Even a lithotomy position, you may produce foot drop. That's where we don't put those stirrups no longer, we keep the leg down. That has been changed now. And whenever any restrainer we are putting, it is done by the surgeon. Position is done by the surgeon. And he is the first person to come and remove all those things. That is the dictum. First thing that should go is restrainers. This is another thing I have already told you. The stomach should be completely deflated. There is always intra-abdominal pressure will increase the pressure on the stomach, and there will be reflux will be there. And if you see, there will be a lot of fluid inside the pharynx, and it may spill onto the eye and cause or aspirate. That's why we always have to be very careful about it. And we did a study here, and we started using suction catheter instead of raised tube. This study was conducted here only. Stomach, the pharynx is completely emptied, and then only we remove the endotracheal. Thermal injury, I think Dr. Ramesh or someone will take class about the cautery and injury that can occur during laparoscopy, how the leakage from the all our instruments are insulated. You may be knowing that the black and insulation is there. So if there is any leak, anesthetist is the first person to say that ECG disturbances is there. Please check your instrument. That's how we recognize the leak, and you should be very careful about this thing. And I will not talk much about this except for the surgical smoke and carbon monoxide thing. At the same time, there may be inadvertent hypothermia because gas is under liquid form. Then gas become gas by losing the temperature. So they have done a lot of studies about sudden expansion and 0.3 reduction of core temperature with every 50 liters of carbon dioxide that enters into the body. So at the end, patient will be having a lot of hypothermia, shivering and other complications. So it is mandatory on your part to see that patient gets the warm gases, at the same time it is filtered also. These are the filtrations that we have put, and also we have got a different type of systems are available now where it will warm the gas before going inside. This is how it will be. Moisture management systems are available now so that we can fix it, and it will have temperature increase, and also it will filter the gas. So we can have temperature, gas supply, gas heating, all this, they are all available now so that we will prevent. Then comes the smoke. So during COVID they said no laparoscopy. All of you know that, isn't it? Why? Why they said no laparoscopy during thank you. Thank you.
Coffee Nena.
So laparoscopy and a regional you can do. I told you, I have given the clue on the table. It is there on the board. Why? Smoke only. That's what you are talking. First we will talk about the carbon monoxide formation whenever you are using cautery. We said the carbon dioxide is there, it will not promote any flame formation. But you see flame coming during your cautery. How does it happen? From where the oxygen came? So carbon dioxide gives away under duress the oxygen, and it will become carbon monoxide. That oxygen is the one that you see as a flame or burn during the cautery. So whenever the cautery is being used, we use a lot of electrical current that will dissipate, it will become carbon monoxide. After 5 minutes of electrocautery, they used a level of range from 100 to 1900 ppm at the end of the surgery. That's the amount of carbon monoxide that will produce. That's why there should be proper scavenging. What they will do, they open, increase the flow, and they close it. That's what they do routinely. Thank you. So these are the gases that they produce during thing. This is the smoke that you are telling. It is because of the cautery and other thing. So it will release 150 chemical hazards. So it may have so many things. It is a toxic gas, it is a toxic gas, dead and live cellular material can release, including the virus. That's why they said no cautery, no laparoscopy during COVID. So we also know one smoke, 1 gram of tissue will release smoke up to 6 unfiltered cigar. And also there will be damage to this one. It may even produce carcinoma. So overall the affected patient, staff, ourselves and the community. So medical team saves life, expose themselves to the day. So we are ignorant about it. We ourselves release residual DNA with infectious papilloma and residual DNA with HIV and other gases. So that they introduced lot of new systems to prevent this one. This is the air seal model they have introduced. This will, smoke evacuation mode will be there, and also it will have different types of filters will be there, so that the person who is operating is safe. These are the different types of 6-layer filter will be there that will try to filter, gas flow will go through it and it will filter it. And it will show you how it is. That one is the with gas, with a filter. So these are the different types of airflow assisted air seal things are available now. So it will not only filter, it will circulate the new gases, fresh gases, and it will give a different type of, your smudged view will go on, clear view also will improve, and it will safeguard the person who are operating and the others. And also the suction catheter itself has got a, suction catheter is attached to your pencil probe, so that gas will be absorbed there only. Whatever the smoke that comes will be absorbed into the system. This is how it looks. That can be adjusted, so all the ports are adjusted. And other things, we usually put hot water, saline and betadine and other things. That can be removed by this kind of a new visibility system that there. It will warm the thing and keep it, and also it will help the white balancing also. And these are the new irrigation systems that have come with warm water and CO2. And this is one thing that where you should be alert when you are depending on the technicians, what they are connecting, how they are, you believe them and start surgery. You think that they are connected carbon dioxide, they may connect to some other port. You should be very, that's how you develop a team, and you should be very vigilant. And how they lost a patient on the table by a technician who connected instead of carbon dioxide. At the same time, we should know how to sterilize the equipment. It is impossible to autoclave and do the specially scope. We cannot clean it, we cannot sterilize it. Scope, once it gets infected, it will go on infecting the subsequent patients. Especially with tuberculosis bacilli, they have done a lot of studies how a scope can induce infection to the others. Secondly, there is a possibility of contamination at the joints. So you should know how to dismantle it, how to connect it, how to clean it, how to scrub it. That kind of exercise is very, very important in these patients. Then comes, if you are using formalin balls and a box containing the equipment, that is the most dangerous thing, because formalin dust can induce sudden acute peritonitis and fluid starts coming out of the ports. And that's where 3-level cleaning is there. If you put an instrument in a Sidex, first it is washed with saline, change the gloves, then hand over the instrument. So 2 things are very important. Don't ask them to give an instrument that is not unsterile, dip it and give it to me like that. You have to plan properly. If you are doing that kind of a thing, you will be teaching them a wrong thing to the theatre. It is not a practice thing. So 3-tub technique is there. If you have got 3 tubs, then it's all right. First, she has to take out, dip in, wait, dip in, wait, dip in, wait, then change the gloves, wash it running water, then hand over. Do you think that they have that kind of a patience? Surgeon has got that kind of a patience to wait for it? No. Give. That should never happen, because it is highly alkaline. Peritoneum was not designed to receive Sidex inside the peritoneal cavity. And also, as I already told you, there is a possibility of you are doing a case, suddenly carbon dioxide drops down to 0, and what gas that is there in the peritoneal cavity will go back into the insufflator. The next patient, subsequent patient, will get the same infected gas subsequently. So backflow protection is very, very important before starting connecting a insufflator. That's a lot of case reports are there. We should be very, very careful. No direct connection of the thing should happen. There should be backflow protection must be there. Then we said about the enhanced recovery care or whatever it is. Especially nowadays, maximum number of cases are colorectal surgery. They compared with the enhanced recovery. What is the plan of enhanced recovery? That's what we said. That will reduce the complication, hospital stay, and because there should not be any pain after the surgery. Minimize the drain or remove the drain, remove the catheter, and early mobilization is the fast track method that we are trying to do. Take the advantage of laparoscopy by proper planning your procedure, planning execution of your procedure. These are all studies that is there. Now this is the single incision technique that they are trying to do it, but it will be more, this one cosmetic laparoscopic is coming, where we use the flexible scopes. This is the robotic thing, that is, a lot of surgeries are being done, especially prostatic cancer and prostatic surgery. That is coming to the colorectal surgery also. And this is remote, and surgeon is 100 kilometers away and is trying to operate in a theatre remotely. This is the thing that they are trying to perfect it. So when coming to the tragic part, or this is what are the complications that can happen, and how we are trying to improve and prevent complication. What are the known complications that can occur? That's what we have to just review it, so that you know that this can happen, that can happen. We also have a lot of things where we had the instances, we had meeting and we try to prevent them as far as this one. New protocol has been drawn to prevent all these things. So our aim is to reduce the surgical risk, reduce the complications, reduce the hospital cost or stay that they are there. That is our aim, but that requires your strict vigilance, and team effort is very important. Gradual insufflation, gradual change of position, and alert experienced staff is very, very important. No diversion in the operation theatre, and intensive postoperative care. Don't lose sight of the patient. Take care of early recognition of the complication is mandatory in laparoscopy. There is a life-threatening intraoperative complication can happen, and physiological trespass can occur at various levels, but we know it. But proper case selection, preparation, and team is very, very important, and also following the surgical principle that you have learned during our open technique. As I told you, it is eternal vigilance is very, very important. Just before closing, I want to tell a story about this. McGurk is a Microsoft very senior engineer, very popular, and he had 2 Ferrari, and he's in charge of half of the world. And he had a son, Ali. He graduated and he got a new job. So Saturday, parents decided to have a party in favor of the son who is leaving the house for the first time. So in a ship they had a party, grand party for him. Then afterwards he developed a pain abdomen. They took him to the best hospital available in Abu Dhabi. Then he is no more. The trocar directly went into femoral artery and died instantaneously. That led him to father resigned and became author, how to cope up with the tragedy and all. He wrote a book and it became a bestseller. But what I am trying to tell is, we cannot take anything lightly. A young boy's life is lost. Okay, this is I don't want any tragedy to occur. So let us have some thing. So it should end up with how many mugs she is carrying?